I'd like to very much welcome you to the next in the session at the third annual symposium of the Western Alliance, and just from a personal point of view, commend the Western Alliance on just how much it has achieved in a pretty short period of time and how far that reach of that work is going throughout Western Victoria. Julie is the head of the Epicentre for Healthy Ageing and the Deputy Director of the Impact Strategic Research Centre for the School of Medicine at Deakin University. And the talk is called Ageing, Chronic Disease and Injury, and it's a study in Western Victoria. Join me in welcoming Julie.
Well, thank you very much to the organisers for the opportunity to present our work today. So I'm going to talk to you about that study, Ageing, Chronic Disease and Injury, a study in Western Victoria, because we received funding from the Western Alliance to get this study underway. So the broad aim was to establish the extent and influence of ageing on disease and injury in Western Victoria. And at the moment we're assembling information from existing medical and administrative data sources to form a contemporary evidence base for the region. And this will be interesting or valuable for monitoring ongoing change, for planning future prevention strategies, and also for evaluating the effectiveness of interventions that will arise from other projects that are funded by the Western Alliance. So today you're going to hear from some speakers presenting some of the work that we've developed from the existing databases. The broad aim of the overall study is to then go into the next phase where we'll sample subpopulations across the region. And I think we must have missed a slide here. No? Okay, so that's our study region. You can see that it extends from Geelong right across to the South Australian border. It's basically the area that matches the primary health network. So it's about a third of the size of Victoria, and it contains populations that are urban, like around Geelong and major centres, but it's also got a lot of farming communities out there. And they're the groups that we want to really try and investigate. So, as I said, once we've got the prevalence data from the existing databases, then we want to go and sample from those subpopulations. And we want to measure the level of chronic disease. We want to find out what the true level of obesity and diabetes is. And then we want to overlay those two to try and identify mismatches, because that will identify gaps in health service utilisation and delivery. So that's the planned next phase. And of course, these data will be able to be used to establish and target the appropriate allocation of resources for prevention, care transition needs, and to better deal with the burden of chronic disease and injury. So we've had the study profile published. That was just published this year. And you can see that there's quite a list of co-authors there because that is the investigative team. So we've got a lot of expertise who are working together to make this study happen. So in today's presentation, we're going to hear from two PhD students, that's Sajjad and Stephanie, and we've also got a postdoc presenting some work. So we're going to hear about hospitalisations for patients living with diabetes. We're going to hear about the incidence of cancers, hip fractures, falls and joint replacements, and these will be presented in terms of local government areas, age, sex, socioeconomic status and remoteness. So I'll introduce our first speaker now, who's Umber. Thank you.
Thanks, Julie. Good day. As Julie mentioned, I am a PhD student at the Impact SRC in Geelong, and I'm part of the ACDI research team. I'll talk briefly about some important socio-demographic aspects of the ACDI region and provide a summary of my research plan. We focus on individuals 40 years and older living in the ACDI region that make up just over 51% of the population. This map shows the distribution of our population of interest. As you can see, there's a general trend of increasing in the proportion of over 40 years old as we move from Geelong here to the more regional LGAs. So we have 46.3% of population in Ballarat that is over 40. That increases to 67% of population in Queenscliff. Queenscliff is basically a retirement community. And if we look at the median age across the region, that follows a similar trend. So we have the youngest population in Ballarat, that is median age of 37 years, and that increases to 55 years in Queenscliff. So that is the broad demographic structure of our population of interest. This region has one of the most socio-economically advantaged areas, LGAs, for example, Surf Coast. It's one of the most socio-economically advantaged areas in Victoria, and the most socially disadvantaged as well. That is Central Goldfields, the local government area of Central Goldfields. So this provides a good opportunity to study these area level indicators and their impact on the health system. This shows the distribution of major public and private health services that are provided in our region. So these white crosses in red background, they show the areas where LGAs, where 24-hour emergency departments or EDs are located and provide major trauma and emergency services. So they are in Greater Geelong, Warrnambool, Ballarat, Hamilton, and Horsham. And then the white H's in blue background show the public hospitals that are distributed across the ACDI region. And the white H's with pinkish background show the private hospitals. And the color distribution is also interesting. It shows GPs to population ratio. So we have a GPs to population ratio of 0.3 in West Wimmera. That's the very light color just near the South Australian border. And we have the highest proportion, that is 2.9 GPs per thousand in Queenscliff. So overall, our study region resembles the demographic structure at state level, where we have one major urban center in Geelong, and then we have areas of varying socioeconomic status and other indicators. And as I said, that makes it a good region to study these determinants and outcomes related to population health. As a part of the ACDI team, my project deals with hospitalizations that are due to diabetes-related hospitalizations. So as we discussed before, as I heard earlier talks, that we want to keep people out of our hospitals and treat them in the community. So I think the first step to address that issue is to know who is being admitted, where do these people live, what is the socioeconomic status, what are other area level indicators of the people who are being hospitalized with chronic diseases. So there's two phases. Phase one, my aim is to map the distribution of acute hospitalizations across the ACDI region, and for that we have requested data from the Victorian Admitted Episodes dataset, the VAED, and once that distribution has been established, the next step will be to look at area level indicators that explain those differences. It's things like socioeconomic status, remoteness, accessibility to services, and availability of health services. Phase two will be an audit of the inpatient data that we plan to do at 4 different levels. So Australian hospitals are classified into peer groups. So we have the Principal Referral Centre in Geelong, then we have Public Acute A category in Warrnambool and Ballarat, and then we have other hospitals smaller hospitals in the next categories. So what I want to do is to do an audit of the inpatient data to see, first of all, to establish the prevalence of diabetes in our inpatient population, because we don't know that at the moment. And the next step will be to compare the profiles of those with diabetes and those without diabetes, and to establish the clinical profiles and to see who is being admitted at different levels of acute care. So overall, the significance of this work lies in the fact that we'll be providing area level information that will be relevant to both clinical practitioners and policymakers. So that is a broad overview, and I'll hand over to Stephanie now, who's the next speaker. Thank you.
Thank you. I'm Stephanie. I'm a PhD student with Impact, and I'll just be speaking a little bit about the Association of Age Accessibility and SES on Cancer Incidence. So just a little bit of a snapshot of cancer in Australia. An estimated 130,000 new cases of cancer will be diagnosed in Australia this year, and that number's set to rise to around 150,000 by the year 2020. And in Victoria, rates are expected to increase by up to 39% by 2025. Cancer is the leading cause of death, accounting for approximately 3 in every 10 deaths, and currently 1 in 2 Australian men and 1 in 3 Australian women will be diagnosed by the age of 85. Overall, there are favourable outcomes in terms of early diagnosis and survival rates. So overall, the 5-year average survival rate is around 66% post-diagnosis, but obviously this changes depending on tumour stream. There are metropolitan versus regional remote differences. In terms of Victorian mortality rates, survival for metropolitan Melbourne residents is higher than for regional counterparts. And the most common cancers in Australia, here excluding non-melanoma skin cancers, are prostate, breast, colorectal, melanoma and lung. And these tumour streams account for over 60% of all cancers diagnosed in Australia. So as part of the ACDI study, we've previously mapped the incidence rates of primary cancer diagnoses across our region. Data has been extracted from the Victorian Cancer Registry from 2010 to 2013 inclusive on all primary cancer diagnoses in men and women, as well as primary diagnoses for our 5 main tumour streams mentioned before. And these incidence rates per LGA for the region were then age standardised to the 2011 ERP for Australia. So what we can see with what we've looked at before is that overall incidence for men is greater than women, and we obviously have age-related changes. And our data here for our region is in line with current national and state trends, where approximately 60% of all incidence rates occur in those 65 and over, and more in the age bracket of the 80 plus. And with the 30 to 49 age group on a national scale, we see a similar result where we have a higher female incidence, and this is largely due to the presence or incidence of breast cancer in that age group. And we can see those national trends here with our ACDI region. Here we have some heat maps that have been developed for our region with incidence rates, again during the 2010 to 13 years, and data is presented as rates per 10,000 persons per year. So we have men on the left and women on the right, and we can see that the LGA with the highest incidence is West Wimmera for men, and then we have Ararat there for women. So now that we've previously mapped the incidence rates, what we wanted to do now was look at or to investigate the associations, I said, of age, accessibility and SES on cancer incidence. Again, this was all age standardised. And on this slide here, we have a bubble plot. So what we have there, the y-axis is age standardised cancer rate for females and males combined, and that's against their accessibility remoteness or ARIA score. So what we can basically see is that the higher the ARIA score, so the further along the x-axis we get, the more remote we get. And the LGAs, the bubbles are represented by the size of the population LGAs. So analysis demonstrated here that ARIA was associated with cancer incidence, whereby those in more remote areas had overall lower rate of cancer incidence. And again, we looked here at SES. So again, we have age standardised cancer rate for males and females combined. Now, low IRSAD scores, so that's Index of Relative Socioeconomic Advantage and Disadvantage. A lower score indicates relatively greater disadvantage and a lack of advantage in general. And a high score indicates a relative lack of disadvantage and then a greater advantage in general. So analyses here showed that SES, again, this was associated with cancer incidence in our region, indicating that those with higher socioeconomic disadvantage, represented by lower scores, were associated with higher cancer incidence rates. I will note that both the plots there, we have significant data, but you can see the slope of our gradient here is low, so we need to be careful when interpreting this, that we have association, not causality. So all this data, these can act as a great platform to assist in identifying gaps and assessing the needs and services of resource allocation across this region. And it can help to assist health service planning and implementation of preventative strategies to ensure better service provision across Western Victoria. Thank you.
So I'm going to talk about a few topics in this brief presentation today, starting with community falls. And that data came from the Victorian Emergency Minimum Dataset, which is a dataset that keeps a record of all the emergency department admissions from specific hospitals across the region. I'll also be talking about hip fractures, and that data comes from the Victorian Admitted Episodes dataset, which is a record of all the hospital admissions across the region. Sorry, when I say region, I mean Victoria. And lastly, I'll talk about joint replacements. I'm only going to talk about hip replacements today because of the time constraint here, but we will be looking at other sites. And that data comes from the National Joint Replacement Registry, which is a big registry that keeps a record of all the replacements in Australia. And all the data for these studies comes from 2010 to 2013 inclusive. Yep, so I'll start with falls here. And this is the map for the incidence rates of falls. And what you can see is that the highest rates are in Horsham, Warrnambool, Ballarat. But this may be due to the accessibility of the 24-hour EDs, as Umber showed in his map earlier. So there might be a bit of an accessibility effect going on here. And you can see some of the lower incidences occur in Ararat, Northern Grampians and Colac Otway. So looking at the bubble plots, the same as Steph just presented, this one looks at age in relation to the incidence rates. What you can see, it's not all that clear what's going on here, but the analysis did show that there was an association with age and the incidence rates, but that might be just because of the impact of Ballarat and Geelong's larger populations driving the association, because they contribute more to the analysis than the smaller populations. So when we look at ARIA for falls, you can see a slight decrease with rates with increasing ARIA scores. So this might be because the more remote areas don't present to the EDs as much because they're just not as close to them. And then finally for SES, again, it's not particularly clear for falls what's going on here, but the analysis did show a small decrease with increasing SES. So moving on to hip fractures now. So this is the map for hip fractures, and you can see the highest rates occurred in Yarriambiack, Hindmarsh and Central Goldfields here. And some of the lower areas were Moorabool, Hepburn, Golden Plains and Pyrenees. So when we look at the bubble plot for age here, it's a much clearer association. You can see very clearly that age has a huge role in hip fracture incidence, where the increase in age results in an increase in incidence rates. Queenscliff's on the corner here, a little bit of an outlier, but largely they all follow that same line. And when we look at ARIA, we do see a slight increase with ARIA and incidence rates. And then finally looking at SES, we do see a slight decrease in hip fracture rates with the SES. So then finally I'll talk about joint replacements, specifically the hip here. So you can see primary replacements on the left and revisions on the right, and you can see certain areas have higher rates than others, but it's important to note that the revisions here are for the person's residential address, not the hospital at which they receive the replacement. So future studies, we'll do a few different things here in the future with our work. So the first one is to stratify by men and women, which we have the data for, we just didn't present today. We'll be doing a manuscript for that should say hip fracture, sorry. And of course we'll look at some other things, particularly activity when injured for falls, arrival transport mode, things like that. And for joint replacements, we will investigate different joints, the impact of access to orthopaedic surgeons, and finally doing a larger multi-level SES analysis. And sorry, I'm a tiny little bit over time, but here are our acknowledgements. So I'd like to thank the ACDI research team, our funding, particularly Western Alliance, and support from the registries and hospitals across the region. So thank you very much.
I think that's a really fantastic and comprehensive study, and also a brilliant example of just how good the PhD students are that are getting generated from this sort of work. I was really impressed. I was sort of half expecting a multiple wrap type of thing, but it was really beautiful and well delivered.